I'd like to introduce our next speaker, Paul Smith. Paul is a senior principal research scientist at Charles River Laboratories, just outside Edinburgh. Paul has 36 years' experience in inhalation toxicology, gained across 4 CROs, including positions such as head of inhalation over a period of 20 years. And during these numerous years of experience, Paul has worked on a wide range of chemical and pharmaceutical studies through to 2-year carcinogenicity studies. Paul is a committee member of the Association of Inhalation Toxicologists and held the post of chairman from 2009 to 2011. Welcome, Paul.
Thank you, Victoria, and thank you for the DDL and the AIT for inviting me to present today. So in terms of the summary of topics that I'll discuss today, I'll look at some inhalation-specific requirements for toxicology studies, discuss preliminary and main toxicology study design, as well as safety pharmacology studies. And then if we've got time, I'll look at some examples of animal models of respiratory disease. So as Tony discussed, some of the formulations that we use for inhalation can be pure powders, active ingredients in an excipient, an active ingredient in a spray-dried formulation. In terms of liquids, it could be the active ingredient formulated in a vehicle, such as PBS, or a messenger RNA in a liquid nanoparticle formulation. We also run pressurized metered-dose inhaler studies. So this is the active ingredient in a propellant, such as the low carbon footprint Zephex 152A. In terms of vapors and gases, these are more infrequent, but for example, THC CPD can become in a vapor form, and nitric oxide as well. So chemical analysis is often required before any aerosol generation. It's not required for pure powders or non-volatile liquids such as oils. However, for most other formulation types, it is required. So it would either be a method transfer from a known method or method development. And then we'd move on to method validation. So the method validation includes investigation of things such as selectivity, calibration range, carryover, etc. And also, and importantly, recovery of test material from the aerosol sampling media. And Tony touched on the different types. So there's more frequently filters for aerosol concentration determination, and metal plates from cascade impactors to determine the particle size. Method validation, method development generally takes 1 to 2 weeks, and method validation 3 to 4 weeks. Now, before we run any animal study, we need to do something that we call aerosol characterization. It comes under many different guises. But the objective of this study is to identify the conditions required to achieve the target aerosol concentration, the target particle size, and I've listed the typical MMADs that we target for a range of species. We also look at the temporal homogeneity. So does the aerosol concentration remain stable over time? And spatial homogeneity as well. Does the aerosol concentration stay the same at different levels of the inhalation chamber or different locations for the non-rodent system? We also look at the performance efficiency, as that's important in terms of the drug calculations required to run the studies. So we work closely with the analytical department to get fast turnaround time of the aerosol samples so that we can move on in the iterative process. So for compounds that we newly receive, we generally take up to 6 weeks for aerosol characterization. But once we are familiar with the characteristics of the test material, then it's more like 3 to 4 weeks. So in terms of the delivered dose, how do we calculate this? Because it's a lot different calculation versus other dose routes. And the algorithm here, or the equation here, is an industry-wide one, and it consists of determining the aerosol concentration, understanding the body weight of the animal, the exposure duration, and the respiratory minute volume, so the breathing rate of the animal. And this is an algorithm. It's in a publication from the AIT, actually, in 2008, in inhalation toxicology. And this algorithm is based upon the body weight of the animal. So we can actually measure the respiratory minute volume during the toxicology studies, but it's not very practical to do so. So the default is to use this algorithm. And we can also add a deposition factor to this calculation, so in order to give a lung dose. And the FDA typically assume 10% for rodents, 25% for non-rodents. And in the clinical situation, then they would assume that the human is actually breathing in 100% of the clinical dose. Anyway, it's an estimation. It's not a definitive dose to the animals. So in terms of dose selection for preclinical studies, then we need to give up to a 50-fold safety margin above the clinical dose for small molecules. And for biologicals, it's 10-fold. And the two variables from the delivered dose calculation that can be adjusted to modify the dose to the animals is the aerosol concentration and the exposure duration. In terms of the aerosol concentration, we tend to vary this between the dose groups for toxicology studies and have a consistent duration of exposure across the groups. So the aerosol concentration is primarily dependent upon the rate of delivery of the test item into the inhalation system. And this can vary with the nature of the formulation, but also the type of generator being used, as Tony mentioned in his presentation. So for example, we could be dosing a pure powder, which is 100% active, or we may be dosing a powder blend, which is only 10% active. So there's a 10-fold difference between the doses that you could potentially achieve with those two types of formulation. Similarly, with liquid formulations, then you might have a low soluble compound or a highly soluble compound. But also, using mesh nebulizers tends to give you a higher aerosol concentration than an air-jet nebulizer. In terms of PMDIs, then the way that we vary the aerosol concentration is to vary the number of the devices that we put into the cartridge. Tony had a very nice video of the MDIs going into the cartridge. So we've got devices that can hold between 1 and 8 PMDIs, and we can also vary the frequency at which we fire these PMDIs into the inhalation chamber. As Tony mentioned, the normal exposure duration is 30 to 60 minutes, but it could be as low as 10 minutes, and as high as 6 hours for rats. For dogs, we tend to limit that to 4 hours. Mini pigs, 2 hours, and monkeys is generally limited to 1 hour. So just briefly, in terms of the inhalation administration, this requires much more material than any other dose route. I did a calculation and came up with a roughly 30-fold difference. But we can be using kilograms of material for toxicology studies. And this is because the animals require a supply of fresh aerosol in a dynamic airflow to meet their breathing demand. But also, there are losses that occur in the inhalation system, and these can range from 30% up to 70%. As Tony mentioned, I think it's a bit of an urban myth that clinical devices have to be used in the preclinical studies. That's not the case. Animals breathe the aerosol in a constant flow of air, so they're given sustained delivery as opposed to a bolus delivery. And often the preclinical doses are much higher than the clinical dose. It's not practical, therefore, to use the clinical devices, certainly for powders and pressurized metered-dose inhalers. Some clinical nebulizers for liquid formulations can be used, though. In terms of the regulatory guidelines, there's a whole host of regulatory guidelines, which I've listed some of them here. The M3R2 guideline is the main one that we would use for small molecules, and the ICH S6R1 is the one that we would use for large molecules. But there are other ones, for example, the safety pharmacology guidelines as well, toxicokinetic guidelines, and guidelines for anti-cancer pharmaceuticals as well. And these are generally compatible with a range of Japanese guidelines from the mid-1990s. So what are the studies that are required for first-into-human clinical studies? So you'll require a genetic tox study, so an in vitro mutagenicity study, an in vitro chromosomal damage study, and as well as an in vivo chromosomal damage study. And we generally run the micronucleus test at our lab. You also require an in vitro hERG channel assay and two animal toxicity studies in 2 species, as well as safety pharmacology studies, which I'll come on to those a bit later on. Okay, so in terms of species selection, so these guidelines require a rodent and a non-rodent for small molecule. For large molecule, then you can just use one species if the clinical candidate is only pharmacologically active in one species. However, I have to say that in my experience to date, that more often than not, we are still running 2 species with large molecules. The rodent species is invariably the rat, and the non-rodent used to be the dog. However, in the UK, the mini pig is now the default non-rodent species. And specific justification is required for use of the dog over the mini pig. Now, Tony showed some nice pictures of mini pigs being dosed, but it's not a straightforward effort. So there's not many CROs that have that capability of running inhalation in mini pigs. And in that case, the dog can still be used. The use of the min pig also, you need to consider your clinical indication. So for example, if you've got potential medication for treatment of COPD, COPD is obviously a chronic disease, would require you to perform a 39-week inhalation toxicology study in non-rodents at some point. And mini pigs don't stay mini for very long. So I just can't imagine ever running a 39-week mini pig study. So in that instance, it might be better to start your program of work already with a dog. And just to mention, in the UK, again, the specific justification is required for the use of the non-human primate over mini pig and dog. So moving on to the actual preclinical study designs. So before you do your formal GLP study, you need to understand what doses you're going to select for that. And normally you would therefore run a preliminary study. Often this is called an MTD DRF study, maximum tolerated dose range finding study. And this consists of two phases, an escalating phase and a repeat dose phase. In the escalating phase for rodents, each of the escalating phases has 3 dose levels and generally dosed for 3 days at each dose level. For the rodents, typically this would only be 3 animals of one gender, and then the MTD is confirmed in the other gender. However, I have to say for inhalation studies, because of their complexity, it is often easier to run both genders at the same time, but not in general toxicology. And in terms of the non-rodent, then you'd have 1 male, 1 female, and you use this pair of animals for each of the escalating dose phases. At least with small molecules, maybe with biologics, you'd need naive animals at each escalation due to the potential of immunogenicity. For the repeat dose phase, it's generally 7 or 14 days of duration. In the rodent, it'd be 3 dose levels, 3 male and 3 female at each dose level, but without a control. And in the non-rodent, you'd have a naive pair of dogs and dose those at the maximum tolerated dose level. You can, however, have an additional pair of animals and dose them at a lower multiple of the MTD. In terms of the aerosol sampling, this is aerosol concentration is determined daily, particle size at each of the dose escalations, and once weekly in the repeat dose phase. And we perform regular chemical analysis during these phases. In terms of the in-life observations, there are daily clinical signs and routine body weight and food consumption measurements. In terms of toxicokinetic investigations and clinical pathology, this is optional on the MTD-DRF study design. But if it's done, it would only be done in the repeat dose phase rather than the escalation phase. And terminal investigations would consist of macroscopic examination, organ weight determination in the repeat phase animals. It's rare that we would do histopathological examination in the MTD-DRF study, but it's perfectly possible. And sometimes for inhalation studies, the client is particularly interested in any effects on the respiratory tract at an early stage. So in terms of the main GLP study, this typically would consist of a control and 3 dose groups. You'd also have recovery in your control and high dose. A second control group is generally not required unless your formulation has a novel excipient that's never been into the human before. So you then need an air control and a vehicle control. Group size in rodents is typically 10 male, 10 female, with 5 male and 5 female in your recovery, control and high dose. You'd also need additional satellite rats for TK investigations. For the non-rodent, typically this is 3 male, 3 female, with 2 male and 2 female recovery, again in your control and high dose. No need for satellite animals for non-rodents. The treatment period is generally for 14 or 28 days to match your clinical duration. And again, routine measurements of aerosol concentration, particle size, and chemical analysis. Excuse me. So again, the in-life observations would be clinical signs, weekly or weekly or twice a week body weight and food consumption measurements. Clinical pathology in the rodent is performed at termination, and in the non-rodent, it'll be performed pre-treatment and again at termination, as is ophthalmoscopy. ECGs are routinely done in the non-rodent, but not the rodent. And this can either be a snapshot ECG, or it can be something called JET, which is jacketed external telemetry. And this just allows more robust ECG evaluation over a 24-hour period. Now, the JET can also include RIP bands in the jacket to measure respiratory parameters. RIP is respiratory inductive plethysmography, and I guess the equivalent in the rodent would be head-out plethysmography. So toxicokinetics is a requirement, and generally this will be done on the first day of dosing, as well as towards the end of the treatment period. And normally we would take blood samples at 6 time points in order to get a kinetic evaluation, such as Cmax and the area under the curve. Terminal investigations, again, would be macroscopic examination and organ weights. And microscopic examination is required for these studies. And that's on a comprehensive list of tissues. In the rodents, this is at first done in control and high dose only. And if there's any treatment-related findings, then we would track down to the low dose, the mid dose, and the recovery animals. As a routine, all animals all non-rodent animals are histopathologically examined. Sorry. So what are additional endpoints for biologicals? So these will be generally measured pre-treatment and at the end of the treatment period in blood, plasma, serum, and bronchoalveolar lavage. Such investigations include immunogenicity, so looking for anti-drug antibodies, and the TK results may indicate the presence of anti-drug antibodies if you have high values at day 1 and lower values at day 28, then that would indicate that there's been some binding of your drug. Cytokines are investigated in a multiplex assay, so a whole host of cytokines. And complement activation, typically this would be C3A, C5, and these are pro-inflammatory agents. We'd also look at immunophenotyping by flow cytometry, so we're looking at a range of T and B lymphocyte populations. Body temperature can be routinely measured, as well as acute phase proteins such as C-reactive protein in non-rodents and alpha-1 acid glycoprotein and alpha-2 macroglobulin in rodents. We can also do immunohistochemistry to look at T and B lymphocytes in macrophages and activated lymphocytes. Tissue distribution studies can be required, although this is more common for vaccines, gene therapy products, and viral vectors. This is just a slide to mention that the duration of the preclinical studies has to match your clinical study. So, for example, if your clinical study is 4 weeks, then you need to do a 4-week tox study. If your clinical study is 6 months, then you need to do at least 6 months, and more like 9 months in the non-rodent. This is just a table lifted from one of the guidelines. So it does have a lot of footnotes and conditions applied to it. So in terms of the safety pharmacology studies, the Irwin screen and the respiratory study are done in the rodent. For the Irwin screen, this is generally 6 males per group, and we would measure body temperature and behavioral, neurological, and signs of overt toxicity. For the respiratory study, by the inhalation route, then this is head-out plethysmography. It's done in 8 males per group and would measure tidal volume, respiratory rate, and respiratory minute volume. And the animals are put into a tube and attached to the inhalation chamber. They have a neck seal, and there's a pressure transducer at the back of the tube measuring pressure differences. Typically, we would measure about 30 minutes pre-treatment, so before the exposure starts, throughout the inhalation exposure, and 1 to 2 hours post-exposure as well. In terms of the cardiovascular study, this is typically done in non-rodents. It requires surgical implants. So generally we have a colony of animals, and this is generally done in 4 males per group, but it can be 2 sexes, so for example 3 male, 3 female. And we're looking at systolic, diastolic, and mean arterial pressure, heart rate, left ventricular pressure, ECG interval data, including the QTc interval. Now for inhalation, we have to do, or it's more efficient to do, an ascending dose design where all animals receive the control, and then a couple of days later, the low dose, and then mid and high dose, as opposed to the Latin square design, which is more frequently used for other routes of administration. In terms of the Irwin screen and the respiratory study, these can be built into the toxicology studies, and this gives let's say, an assessment of repeated exposure rather than single dose. And the clinical route of exposure should be used for your safety pharmacology studies, but if, for example, there's a low systemic exposure, then you can use another route of administration. Have I...
5 minutes left, Paul.
Sorry?
5 minutes left.
5 minutes, okay, thank you. Okay, so there are many models of respiratory disease. So all the ones that are grayed out there, there's asthma, cystic fibrosis, cough model, influenza, or COVID models. So I'll just briefly discuss probably just the acute pneumonia model now, but might get onto the LPS model. So Pseudomonas aeruginosa is a major cause of ventilator-acquired pneumonia and is a risk factor for the adult respiratory distress syndrome. So in this model, rats are administered this Pseudomonas by oropharyngeal aspiration. And then, about an hour post-infection, the rats are exposed to the test material by inhalation at various dose levels. And some work that we did at our lab was testing the antibiotic amikacin and fosfomycin. And the control animals are just given the Pseudomonas with the vehicle aerosol. So the animals are monitored for 6 hours. Body temperature is measured, and the lungs are collected to determine the number of colony-forming units. And this just demonstrates that the Pseudomonas infection causes a body weight temperature reduction, which is maximum in about 2 hours. And the amikacin and the fosfomycin limited that reduction in body weight in a dose-related manner. And then in terms of the CFUs, the red column is the vehicle control, and then all the green columns are different doses of the antibiotic, showing a reduced number of CFUs in the lung. In terms of the LPS model, so models of acute pulmonary neutrophilia in response to lipopolysaccharides can be used to investigate the effect of targeting mechanisms related to neutrophil recruitment. And this is pertinent to diseases such as cystic fibrosis and COPD. So in this model, the compound of interest is dosed 1 hour prior to the challenge with the lipopolysaccharide, This is commonly E. coli formulated in sterile PBS. And then also we give a reference test item, so positive control, which is dexamethasone. And here you see that the black column is the vehicle control, or negative control, so there's no LPS given there. The LPS is a red column with the vehicle and demonstrates a high level of neutrophils. And then the blue columns are different doses of the dexamethasone, indicating a reduction in the amount of neutrophils. And finally, this is just a time course of the neutrophilia. So there's increasing number of neutrophils with increasing dose of the lipopolysaccharide. And then the chart on the right indicates the time course, which is over 24 hours, indicating that the peak response in neutrophilia occurs 4 to 8 hours after inhalation, LPS administration. And just finally then, this model can also investigate some cytokine mediators. So for example, interleukin-6 and KC-GRO, which are elevated after LPS stimulation as well. Okay, and I better call it a day there. Okay.
Thank you.
Thank you.